guys. Thank you very much. Once again, it's the Weekend Health Talk, and I am humbled to be your host, Dr. Obasedo here. We do this weekly to help reduce the level of high misinformation on social media, especially pertaining to medical issues. The aim is to engage specialist doctors on the field to share with us on topical issues. And today we have one of such. He's a brother, he's a friend. He is an emergency physician specialist. There are not plenty in the country, there are very few. He's a consultant to the Ghana Ambulance Service. So when you see the emergency medical team, their competence, he's one of the people who train them. He's practicing currently at the Anglo Gold Ashanti Health Foundation at Obuasi as a senior management member there. Guys, please help me welcome Dr. John Benin JC to share with us on the topic abdominal pain. What could possibly cause it among all age groups? Over to you, John.
Okay, all right. Thank you very much, Albert. Just a correction to one of the introductions. I'm not a consultant, I'm an instructor. So I instruct the paramedics in training on basic life support, advanced trauma life support, advanced cardiac life support, and other issues. I'm not yet at the level of a consultant, but we will get there one day. All right. So, okay, so I'll just share my screen so we can start right away. Okay, I hope you can see my screen.
Yes.
Okay. All right, so I chose abdominal pains because it's quite a common presentation in the emergency department. Everyone, I won't say almost everyone at a point in time will experience abdominal pain. And it's important that you know what could be going on, you know what to do when you have such abdominal pain. So that's why I chose this topic. It's a bit biased towards the adults in the hope that in future talks, a child health specialist may also tackle it as it pertains to children. So bear with me. My name is John. I'm an emergency physician specialist. I work at the Anglo Gold Ashanti Health Foundation in Obuasi. And there I am the head of the accident and emergency, as well as the intensive care units. Okay. So by way of introduction, any pain that you feel that is between the bottom of the ribs and then the pelvic area. For those of us who are healthcare workers, sorry, I try to break it down so anybody who is listening to me as much as possible will understand what I'm talking about. So from the bottom of the ribs to the pelvic area, anywhere that you feel the pain, you have abdominal pain. And it's not stomach pains or stomach ache, as some of us like to say. 5 to 10% of all ED visits are because of abdominal pains. So about 5 to 10% of all patients that come to the emergency departments, they come because they have abdominal pain. And out of these that come to the emergency with abdominal pain, about a quarter of them have a serious underlying cause that requires admission or acute hospital care. Now, I don't think it's surprising to say that the incidence and the prevalence is higher amongst women than in men. Okay, the incidence is higher amongst women than in men. The pain may be severe or may be mild, And patients typically describe it in various ways. Some will tell you they have a stabbing pain. Some will tell you they feel like somebody has hit them in the abdomen. Some will tell you they feel like there is fire in their abdomen. All sort of descriptions, especially in our local language, all sort of descriptions. And the pain may be localized. It may be felt in a particular area of the abdomen, or may be felt throughout the abdomen. May be felt throughout the abdomen. So I want to take my listeners on a bit of a journey to learn some bit of anatomy. So we are taught to divide the abdomen either into 4 quadrants or into 9 regions. So the first image you are seeing, we've divided it into 9 regions. And each of these 9 regions, as you can see there, it has the organs that are most likely located in that particular region. And then the area, the name of the area is also stated there. Okay, so let me go straight to the names. So we have the right upper, the right hypochondriac region, the left hypochondriac, epigastric region, right lumbar, umbilical, left lumbar, right iliac, hypogastric, and then the left iliac regions. Okay. And as you can see that various organs can be found there. Okay. So when you say you have stomach pain, it's technically incorrect for you to say that you have stomach pain when you want to describe abdominal pain, because it's not only the stomach that fills the entire abdomen. There are several organs that fill the abdomen. Okay, I think I will come back to this slide later in terms of the causes of abdominal pain. I'll come back to this slide much later. If you wanted to divide the abdomen into 4 quadrants, then you have a right upper quadrant, you have a left upper quadrant, you have a right lower quadrant, and then a left lower quadrant as well. So these are the various quadrants. If you divided the abdomen into 4 quadrants, these are the various quadrants that you have. This is much simpler. A lot of clinicians prefer to use the quadrant classification because it's much simpler and easier to do, instead of remembering all the 9 regions, sorry. Now, some abdomen or some abdominal pains, we term them as surgical, and some abdominal pain causes, we group them or term them as being of medical cause. Across all age groups, we do this classification, not for the sake that those that have a surgical abdomen or a surgical cause of the abdominal pain will necessarily have surgery. But then in medicine, we have divisions, or we have different specialties, and depending on the specialty and what they specialize in managing. So some causes of abdominal pain is better managed by a surgeon, and then some are better managed by internists or internal medicine specialists. So that's how come we group them as such. Now I have to still say that some of these surgical causes, they will end up needing surgery to take care of whatever was causing the abdominal pain. So in terms of the management tool, that's how we classify them. These are some common causes of abdominal pains. And for the first parts that I've listed, most of them may not even need admission. Okay, most of them will not even need admission. Some of them, they are detained for a while, and then they are given treatment and then discharged home. So for the first part that I'm giving you here, most of these causes they are not serious in quotes. They are not serious. And I say that seriousness in quotes. Okay. So you may have digestive issues, indigestion. Some may have problem with gas because certain foods are known to generate more gas than others. Some may be having abdominal pain because they are constipated. Some, the opposites, they may have diarrhea. Okay, they may have taken something that is causing them to have diarrhea, which is associated with abdominal pain. In children, food allergies and intolerances. So some children have intolerance to certain foods, especially to milk and then other proteins. So these children, when they are given such foods, they will always be complaining of abdominal pain. And sometimes it takes a lot before the parents are able to exactly identify what the child is reacting to. So sometimes we make you do a food diary. You tell us what the child ate the previous day, then we look at it and then compare to the symptoms they are having. Then to another time when they have the pain, what the child has eaten. So food allergies, food intolerances, food poisoning. Food poisoning doesn't mean somebody has put some poison intentionally in your food. No. If you eat food that is contaminated, you may get food poisoning. You may get food poisoning, either because the contaminants or the microorganism causing the food poisoning, they have produced a preformed toxin. Okay, so some of them, they produce preformed toxin on the food. And then when you eat the food, this preformed toxin straight away goes to cause symptoms of food poisoning in the person. Sometimes you take the food contaminated with these microorganisms. Then it is when they get into the body that now they establish an infection and cause their effects. So either preformed toxin or the bacteria or microorganism being ingested, it can lead to food poisoning. Okay. The cause may be inflammatory. So a lot of the times, especially in children, they may have a viral gastroenteritis. So this means that they've eaten food, that food was contaminated with a virus, especially the rotavirus and enteroviruses. These are viral infections that can cause diarrhea and then abdominal pain in the patients. Okay. And most of these viral gastroenteritis, when the patient develops it, they are self-limiting. It resolves on its own. So no treatment may be necessary apart from the person replacing the fluid they may have lost because of the vomiting or the diarrhea. Okay. Peptic ulcer disease. These days, a lot of people have labeled themselves as peptic ulcer patients without ever being diagnosed of peptic ulcer. Okay. So peptic ulcer also develops when there is a break in the mucosa lining the stomach. And usually this is because there is a bacterial infection, a bacteria called Helicobacter pylori. This bacteria can cause you to develop peptic ulcer. Okay, we know that the stomach has a very thick lining that is resistant to acid because the pH in the stomach is very low, it's very acidic. You need that acidity so that it will aid the process of digestion. So imagine now having the lining of the stomach being compromised. Then it means the stomach wall itself is exposed to the effect of acid. And we know acid can, cause irritation, even if it touches your skin. So peptic ulcer can cause severe pain in patients. Okay. Chronic acid reflux. So those who have gastroesophageal reflux disease. Now, the part of the esophagus that goes to the stomach it passes through a portion of the diaphragm, okay? And there is a sphincter there, there's something like a valve at the end of the esophagus. That valve is supposed to prevent the acid in the stomach from coming back out through the esophagus. So sometimes when that valve is not functioning well, then patients develop what we call gastroesophageal reflux disease. So now there is reflux, okay? There is backflow of acid from the stomach into the lower portion of the esophagus. And in fact, this can cause severe pain in patients, okay? This can cause intense pain in patients. So that is also a very important cause of abdominal pain in patients. Then sometimes urinary tract infections. Urinary tract infections can also cause abdominal pain. So never forget that sometimes UTI can also lead to infection, abdominal pain in the patients. Relating to the female genital tracts, sometimes at the time women are having their menses, they may have menstrual cramps. Okay, they may have these menstrual cramps, or some will have ovulation pain or Mittelschmerz. Okay, they will have pain at the time that they ovulate. So sometime after their menses, somewhere around 2 weeks thereabout, they may have ovulation pain or Mittelschmerz in females. Okay, so I've talked a lot about some of the seemingly benign causes. I didn't say they don't cause severe pain. I said they are seemingly benign. Means that, yes, the patient may be having pain, but it may not be indicative of a severe disease. Okay. Now, for the serious causes, the location and other characteristics will determine the likely cause of the abdominal pain. So where the patient feels the pain the most, and then certain other features will likely determine the cause of that abdominal pain. Some of them I will highlight in red when I go down there, okay? For the purpose of this discussion, I use the quadrant system to make it simple for my listeners. So there on your upper left side of your screen, you can see an image of the abdomen. Okay, so right upper quadrant means if you divided your abdomen into 4, okay, one line through the middle from your chest down to your pelvis through the umbilicus, and the other one at the middle through the umbilicus as well. If you did that, you will have 4 quadrants. So the side that is towards your here, okay, above the umbilicus on your right side, that's your upper right quadrant, okay. And in your upper right quadrant, pain is usually related to the liver or problems with the gallbladder. The gallbladder is closely related to the liver. Those of you who butcher animals, when you see the liver, there's usually something green be embedded inside the liver, okay, containing bile salts. In my local dialect, we say all right, so that's what the gallbladder is. It stores certain juices that also helps with the process of digestion. Sometimes you can have problems with it, and these problems can cause you pain that is felt mostly in the right upper quadrant area. So these are some of the problems that could be the cause. Hepatitis. Hepatitis simply means inflammation of the liver, and it could be related to alcohol abuse. It could be related to taking certain toxic medications. And it's known, I mean, in hospitals, we see some herbal medications actually causes toxic hepatitis. So you see patients who come in with this, all right? sometimes metabolic causes as well. The cause may be viral, hepatitis B, hepatitis C. In fact, hepatitis A, B, C, D, all of these can cause hepatitis. Sometimes autoimmune. Your immune system attacks the liver, okay, and then you develop hepatitis. Gallstones. Gallstones is when you have something like a stone. Sometimes the certain chemicals in the gallbladder, they mix up and then form what looks like a stone. It's the normal stone that you know. So these can be embedded in the gallbladder and cause significant pain. Okay. And then there may be inflammation of the gallbladder itself, which we call cholecystitis. Okay. Sometimes the bile ducts, the ducts that leads from the gallbladder, okay, or leads from the liver, joins with the ducts leading from the gallbladder. All these can develop, you can develop a stone in or a narrowing. Maybe you've had repeated infection or inflammation. So you can have narrowing. There is scar formation and you can have narrowing, which causes a stricture. Or cancer, you can have cancer of the duct itself, or the gallbladder or the liver itself too can be cancerous. So these are the commonest causes. Of course, there are other causes of right upper quadrant pain, such as having a kidney stone or duodenal ulcer or a large bowel obstruction. Sometimes you may have an obstruction in your large bowel, and because it passes on your right side, you may have pain that is felt in the right upper quadrant area. If we took the left upper quadrant area, again, if you divided the abdomen into 4, then on the left side, in the upper area, just below the ribs on your left side, that's where your left upper quadrant is. And you may have the structures that are located there. The pancreas is there. So you may have problems related to the pancreas, either cancer or inflammation. You may have an enlarged spleen, okay? Or the stomach lies slightly to the left, it lies to the left side. So inflammation of the lining of the stomach or the whole wall of the stomach can give you that. Ulcer, okay? And then cancer of the stomach or kidney infection. Again, kidney stone can be felt on the left side because you have one kidney on the right, you have another kidney on the left. Okay. Then you may have some causes that are not necessarily from the abdomen, but then they are transferred. The pain is transferred onto the left side as well. So a patient having problems with the esophagus, maybe they have a reflux of acid in the esophagus, or they have inflammation in the lower esophagus. They may have heartburns. Angina is related to the heart, okay? Or you may have non-cardiac chest pain, such as the rib cage itself. It may give you pain, okay? You can have costochondritis. Heart attack as well. Inflammation around the lining of the heart, pericarditis, or a pneumonia can all give you referred pain. And then a pulmonary embolism as well can give you pain. For the lower abdomen, where necessary, I'll highlight. But the left lower quadrant, the right lower quadrant, similar causes. You may have irritable bowel syndrome, inflammatory bowel diseases. Some people have certain conditions called Crohn's disease or ulcerative colitis. Some may have large or small bowel obstruction. Those I've highlighted in red they are acute presentations. Let me put it that way. They are acute presentations. Of course, the others are also serious, but these are acute. That something needs to be done about urgently. So small intestine cancer, colon cancer, abdominal aortic aneurysm, peritonitis, that's inflammation of the lining of the whole abdomen. You can have inflammation of the lymph nodes that lie within the abdomen, mesenteric lymphadenitis. You can also have This mesenteric lymphadenitis is quite common in school-going children. Okay, sometimes they have abdominal pain. You investigate them for everything and it all comes back negative. Then sometimes you do an ultrasound scan and then you see that the lymph nodes are enlarged. Okay. Mesenteric ischemia. This is when the vessels that supply the entire abdomen or the guts, there is some obstruction to blood flow within them. So the gut is not really receiving enough blood as it should. And this can occur in patients who have sickle cell disease, for instance. Patients with hernia, whether it is inguinal hernia or it's umbilical or it's at the site of a previous operation, that's an incisional hernia. Hernia simply means a weakening in the abdominal wall. Let me put it that way simply. So it's not only men that get hernia. Some people have that wrong impression that it's only men that get hernia. Women can get hernia as well. Hernia simply means that there is a weakness in the lining or the covering of the abdomen. If you have weakness in the fascia that covers the abdomen, then there may be abnormal protrusion of organs from inside your abdomen. Okay, and then that comes out and we see it out as a hernia. Appendicitis. Since most of my audience are young men, young women, and young men, appendicitis is a very important cause of abdominal pain. Kidney stones as well, as we mentioned for the upper quadrant areas, the lower quadrant areas too. You can have stones forming in the kidney, and these stones may be passed into the ureter or may be passed into the bladder. All of these can give you lower abdominal pain. Okay, so I just put this image here to show what appendicitis looks like. Appendicitis simply means inflammation of the vermiform appendix. So this is your large bowel, okay? Your transverse colon, your descending, your ascending colon. And then we have the cecum here, okay? And then at the end of the cecum is where you have the appendix attached. The appendix is described as a vestigial organ. It doesn't really perform any function in the human being, okay? But it's there, it's at the tip end of our large bowel there, okay? And it's a finger-like projection, as you can see there. So sometimes the lining of the appendix, it can get blocked. And when it gets blocked like this, it reduces flow of fluids through it. And when this happens, then there is bacterial infection of the appendix. And then when you have bacterial infection of the appendix, that comes with a lot of inflammation. So in the inflammation is what you are seeing there. The appendix becomes bigger. It becomes very painful, very, very tender. Sometimes the patient cannot even straighten themselves. They just have to bend themselves so they don't feel the pain so much. Okay, so that is appendicitis. Commonly occurs in young people, like I said, teenagers, people in their 20s, 30s, getting towards the ends of their ages. Usually, you don't have those people having appendicitis because by that time, the inner lining of the appendix is scarred. Okay, it's scarred, and therefore, it's not really prone to that obstruction I talked about. So again, in the lower abdomen, sometimes you may have pelvic organs, problems with pelvic organs also causing the abdominal pain. So endometriosis is a condition where you have what lines the inside of the uterus occurring outside the uterus, okay? So the lining of the uterus, the endometrium can occur outside the uterus anywhere. Can be outside the uterus itself, on the body of the uterus, or can be in the abdomen, can be in the skin, can be in the lungs, can be anywhere. Okay, so you can have endometriosis occurring like that. Ovarian cysts. So this is when you have fluid-like collections in the ovary, all right? And sometimes this ovarian cyst will make the ovary prone to twisting about itself in a condition we call ovarian torsion. If a woman has ovarian torsion and is not discovered early, then the ovary may not receive blood and therefore die off. Okay. Pelvic inflammatory disease, the name is self-explanatory. So this is inflammation of the pelvic organs, all right? Inflammation of the pelvic organs. It's usually an ascending infection. They have the infection outside that tracks inside along the female genital tract, okay, into the pelvis. So they may have a collection of fluid, pus, or just normal fluid as a reaction to the pelvic inflammatory disease. Ectopic pregnancy, very, very important to take notice of this. The woman complains that they have missed their menses. Then a few weeks later, they start having severe abdominal pain. They start feeling dizzy. They may collapse. Then they are rushed in. As a healthcare worker, I mean, you will not be forgiven if you don't think about ectopic pregnancy in a woman who has presented to your emergency with abdominal pain. So we say that if you are within the reproductive age group and then you come to the emergency and you have abdominal pain, please, we will test your urine. We trust you, we believe you, but we will still test your urine for pregnancy, just in case it is ectopic pregnancy that is there. I have so many stories that I could share that would buttress the point I'm making. We've had patients supposedly who are celibate coming to us with abdominal pain. Then you wonder, okay, I've thought about everything, I've given pain relief. Okay, let me think about pregnancy-related abdominal pain. And lo and behold, such patients have been found to, some patients have been found to have ectopic pregnancy for that. Ectopic pregnancy simply means pregnancy that occurs outside the uterus. It occurs outside the inside of the uterus. Okay, so I'll show an image that will better explain what I'm trying to say. Maybe the English is not coming out well, so I'll show an image, maybe that will help me explain it better. Patients with uterine fibroids, some of them, sometimes, especially when they have degeneration of the fibroid grows faster than it can receive enough blood supply. You may have degeneration and then have pain, okay? Ovarian cancer, uterine cancer, all these are pelvic causes of the abdominal pain. Okay, so here is an image showing the female reproductive tract. You can see this is the uterus. This is inside here that usually after an embryo is formed, it's supposed to come and attach to the inside of the uterus here and then grow there, okay? In ordinary terms, we say womb, but it's a uterus, okay? So sometimes, for one reason or the other, the pregnancy doesn't come and lie here. Sometimes it may lie here at the femoral end. It may lie in the isthmus of the fallopian tube. So there's a fallopian tube. Sometimes it may lie in the interstitium, okay? All these are areas where the fertilized ovum may come and implant and grow, all right? Usually when the male and the female meet, the sperms pass through the vagina, gets through the cervix, uterus, and then goes into the fallopian tubes, and then egg from the ovary passes here and meets the sperm somewhere in the fallopian tubes, and then there is fertilization. After fertilization, the normal thing is that the formed embryo, the zygote should come and then implant in the inside of the uterus here and grow here. So sometimes, maybe because the patient has had some procedures or has had some infections in the past, the fallopian tube may not be so patent, it may not be so open. So the embryo gets arrested there and then starts growing there. Okay. Sometimes too, it's fertilized and then it's even extruded out into the abdomen. So ectopic can occur anywhere, can occur here, can occur there, can occur here, can occur. Sometimes can even come and lie in the cervix. Okay. I have operated on a patient whose pregnancy did not grow inside here. It went all the way into the abdomen and then was lying on a structure that we call omentum. Okay. Pregnancy was embedded there. It grew to an extent that it ruptured a blood vessel inside. So we had to operate, get the bleeding vessel, tie it up, and then take out the pregnancy that was growing outside the uterus. I'm spending time on this because a lot of young ladies, some have lost their lives because of ectopic pregnancy. Okay. I shared a story with Albert a few weeks ago, a woman that we saw with ectopic. She had bled about 3 liters of her blood into her abdomen and had a cardiac arrest. Her heart basically stopped beating. Okay. But we had a wonderful team around. We were able to resuscitate her, get her blood, wheel her quickly to theater and stop the bleeding and give her a chance at life. Okay. So if you suspect that you may be pregnant, okay, the first thing you do is to confirm that indeed you are pregnant. And usually, most of the test kits that use urine from 6 weeks, some early as 5 weeks thereabouts, is able to tell you that you are pregnant. If you confirm that you are pregnant, then the next thing is to have an ultrasound done. Okay. For the ultrasound that is done through the abdomen, usually from 6 weeks thereabouts, they are able to tell that the pregnancy is inside the uterus. Okay. Otherwise, then they will have to look for the pregnancy, whether it's forming outside the uterus or not. Okay. So the next step is to get your ultrasound done and confirm that the pregnancy is within the uterus. I understand some may have unwanted pregnancy and all that. Fine. I've known some patients who didn't want their pregnancies. Once they tested positive and then they knew that they were pregnant, they went ahead, took certain drugs on their own to abort their pregnancy. And unfortunately, that pregnancy wasn't even in the uterus to begin with. So such patients presented late, much later with abdominal pain and then the ectopic pregnancy, which had ruptured. So imagine this growing here within this thin tube. See the way it has stretched it. So soon it ruptures the tube and then ruptures blood vessels, and there's a lot of bleeding into the abdomen. Okay. So it's an important cause of abdominal pain. Now you have abdominal pain. What should you do as first aid? So the first advice is to rest the bowel. If possible, you stop taking anything by mouth. If not, taking water, okay, or taking easily digestible food. Sorry for my spelling mistake there, okay. It's digestible, not digestible. All right. So you rest the bowel, stop eating, or you taking easily digestible food such as banana or some biscuits, or you take in water or clear fluids. When I say clear fluids, a drink is a clear fluid. Okay. Cocoa is not clear fluid, so you can get a distinction. All right. Clear fluids doesn't contain particulate matters. All right. Then as part of first aid, you can take in an over-the-counter pain reliever such as paracetamol. Please as much as possible, unless you know the cause of the abdominal pain, don't take in NSAIDs, non-steroidal anti-inflammatory drugs, such as ibuprofen or diclofenac. Some even abuse hard NSAIDs, such as indomethacin. Please, you may cause more damage than good. So take note of that and avoid those medications. Depending on your history, then you may take in antacid suspension. Okay, maybe you are known to have acid reflux, or you are known to have peptic ulcer. So it makes sense that if you are having abdominal pains, then you may decide to take an antacid suspension. Okay, those who have cramps, especially menses related cramps, I mean dysmenorrhea, sometimes warm compresses also helps. Okay, get a warm bottle. I didn't say hot, warm bottle, and then press it against the lower abdomen. Okay, or some warm towel. You put it in the lower abdomen. It helps to relieve the pain associated with cramps, especially. If you did this and then within few hours, the pain character is changing, okay, then you need to report to the nearest hospital. Or let's say you've done some first aid, a few hours later, you are still having the abdominal pain. Then this is a pain that you need to report to the nearest hospital so you can be assessed, okay? Now, if you have these, then I want you to report to the hospital for medical attention as soon as you can. When your pain is persistent or is severe, or pain that was mild before, now the intensity changes, it becomes severe. Pain associated with pregnancy or a missed period. If your abdominal pain is associated with fever, nausea, or vomiting, or jaundice, again, you should report to the hospital. Pain associated with gastrointestinal bleeding. So maybe you went to toilet, you saw some blood, or you went to toilet and you've seen that the color of your stool has changed. Now the stool that you are passing is black, okay? They describe it as black tarry stool that is like coal tar, okay? It's because you are bleeding in the upper intestinal tract and acid has denatured the blood. That's how come that stool is now black. So black stool is actually blood that is altered, that is coming out. Or sometimes some patients are even vomiting blood. Just this week, we had a patient who has been managing himself in the house. He had presented to us before. He came in vomiting dark colored substance or coffee ground substance. So we advised him that he needed to see a gastroenterologist to have an endoscopy done to determine the cause. So for whatever reason, he stayed in the house treating himself. He came in bleeding profusely this time, vomiting a lot of blood and passing dark stools as well. Okay, so that patient was in a very severe state. We had to do something about. If the pain is worse with movement or is associated with shortness of breath, please see the medical professional as soon as possible. See the medical professional if you have that. Now, these are some questions that if we saw you in the hospital, we may ask you. So we may ask you the onset of the pain, the site, exactly where in the abdomen you feel the pain, okay? What makes the pain worse or better? What is the pain related to meals or to hunger? And then the quality of the pain. So like I was saying, some will describe a sharp pain, some will describe a dull ache or a burning sensation or a tearing sensation. Then radiation. Does the pain go to any other part of the abdomen or any other part of the body other than the original site of the pain? Some will describe abdominal pain that they feel in their chest as well. Some will describe abdominal pain that goes to their back, okay? And then your healthcare worker may ask you to grade the severity. So sometimes they will tell you, okay, I know you are feeling pain. Can you grade it for me? 1 is mild pain or 0 is no pain. And then 10 is the severest pain that you've ever had. On that scale, where will you rate the abdominal pain? All these give us an indication as to what may be going on. So when we ask these questions, please take your time and answer them, because you are helping us to also help you. Then the timing. The timing is also important. How long has the pain been there? Is the pain getting better or worse, or is the same? Then also the associated symptoms. So is the abdominal pain associated with fever, jaundice, vomiting, nausea, etc., loss of appetite? All these also give us an indication as to what exactly may be causing the person's abdominal pain. So these are very important questions that we ask that helps us to formulate what may be going on with you. So you may also be examined, and typically when we are examining you for abdominal pain, the examination will involve a general examination of your vital signs such as your blood pressure, your heart rates, oxygen saturation, your temperature, and all that. Then your healthcare worker will do a focused abdominal exam. So here, they may expose you a bit. I mean, they are supposed to expose from the xiphisternum or from the top below your ribs to your pelvic area, whilst maintaining your dignity. Okay. Then their examination will involve inspection. So they will look on your abdomen. They are looking for any signs of masses or scars, sometimes the hair distribution, all those things they will look at. Whether there are dilated veins on your abdomen, they will look at all those things. Then they will also palpate. Palpate means that they will touch your abdomen. We know your abdomen is paining you, yet we have to touch your abdomen. So in a gentle manner, they will touch your abdomen to feel where it is most tender. Okay, that gives us an idea about what the cause may be. All right, it gives us an idea about what the cause may be. So they will check for tenderness. They will check for a sign called guarding. If you have pain in your abdomen and they are trying to touch, naturally, by reflex, you tense your abdomen, and we call it guarding. When you tense your abdomen like that, we call it guarding. And usually if a patient has tenderness, when we touch, and then the patient is screaming in pain, and then they are also guarding, they are making the abdomen tense when you touch, then we think that that patient likely has a surgical cause. Okay, they have a surgical cause. The surgeon needs to see and decide whether it's an abdomen that they need to explore in theater or not. Okay. Sometimes the healthcare worker will also listen to your abdomen with a stethoscope, listening for bowel sounds. Okay. You will listen for bowel sounds, whether bowel sounds are present or absent. In surgical causes, usually bowel sounds may be absent. Okay, that's for the inflammatory causes. If it's an obstruction, if there is an obstruction to the intestinal flow, then they may have high-pitched bowel sounds, more frequent than normal as well. Okay. The healthcare worker may do other examinations as necessary, okay, depending on what is being suspected. And then from there, they order the right kind of investigations. The investigation may be imaging, may be laboratory-based, they may do endoscopy, X-ray, ultrasound, all these various modalities of investigation. We don't have one that is superior to the other. It's dependent on what we suspect you have that we choose the kind of investigation that we want to do. Okay, so depending on what's from our history, from our examination, depending on what we think you have, then we decide on which investigation we need to do. We are coming to the end of the presentation. So treatment will also depend on the cause. If it's a medical cause, we treat it medically. If it's a surgical cause, then the surgeon will counsel you, explain to you what the surgery will involve, let you sign a consent form to show as evidence that you agree to be taken to theater and then operated on. When you're operating on somebody, you are cutting the person, you're actually inflicting trauma on the person. So you need permission to inflict that trauma that will ultimately save the patient's life. Okay. Most patients with abdominal pain are discharged from the emergency departments. So about 75% of them, that's more than 3/4 of them, are discharged after an initial evaluation and management. About 1/4 of them are admitted, about 20 to 25% of them. And out of these 20 to 25 that are admitted, again, about 1/4 of these that are admitted will need surgical intervention. Okay, so this one, a surgeon will be best placed to tell you about the specific conditions and then the kind of surgery that will be done. So the outcomes usually will depend on the etiology. If somebody has appendicitis, for instance, and they come in early, if you come in early enough, it is without complications. So the surgeon who goes and then takes out the inflamed appendix. And within a few days, the patient is back to what they were doing. If it's ectopic pregnancy and the patient comes in early, they may come at a time that it hasn't ruptured yet. It hasn't ruptured maybe the fallopian tube yet. So the patient may not be bleeding and losing blood into the abdomen. So at that point, it's a bit easier to manage. Okay, sometimes those are even managed without surgery. They are given medical management. Sometimes they are managed with minimal invasive surgery, okay, where they don't really make a big cut on your abdomen. They make some small incisions, use certain probes to operate and take care of that. Okay, obviously, if the person is coming late when it has ruptured, then most of the time, not most of the time, then something needs to be done operatively. So such patients are operated on. If it's peptic ulcer, there are medications to treat peptic ulcer. So the healthcare worker will be best placed to know the exact cause after having gone through all the process that I've taken you through and then come to a conclusion. Then they will give you the treatments that is necessary. Okay. So that is the end of my presentation. In the background is my ICU. I was fortunate enough that day not to have any patient on admission. So I'll pause here, hand over the baton to Albert and take your questions. Thank you very much.
So what Dr. John JC is trying to say, that's his playground. That's why he plays, his ICU. Yeah, thank you very much, Doc, for such a deep expose. As you can all tell, he's an expert when it comes to emergency situations. And the causes are quite a lot. And he tried to go through each and every one of them so that we have an idea what could possibly be causing the pain you are referring to as stomach pain, which he clearly stated is not stomach pain, abdominal pain. And based on the region and how the pain is or whatever, the causes could be different. Thank you very much, Doc. Anybody has any questions, please put in the chat box in the comment section and Dr. John will gladly answer for it. But before he comes through, Doc, please, I have some few questions. I want you to, you said it earlier in the presentation, but I want you to just touch on again, what is food poisoning? Oh, sorry, Dr. John is dropped off a little. His network, okay, he's coming back now. He's coming back. Sorry. I think his network just played a little prank on him. He's coming back briefly. Yes, I wanted him to touch on some very, very key things. So if you have any questions, please drop them in the chat box. Drop them in the chat box. He will come to answer all the questions. I'm here with you. Thank you very much for joining us. Thank you very much. We appreciate you all. Please Drop your questions in the chat box in the comment section on Zoom and on YouTube. And feel free, he will come back to answer all the questions. Thank you very much. Thank you very much. He's back here now. So I'm getting him back on the hot seat. All right. Thank you very much. And yes, he's joining us back. All right. All right. 2 seconds. He's joining us. He's back. All right. So, yes, please drop your questions in the chat box, Dr.
Hello. It's,
Yes, you are back.
yes, I'm back. There
Thank
was a
you.
question you asked.
Yes, I said you said it. You expatiated on it during your presentation, but just a few people who join us late, or just for emphasis, I want you to help me explain to us all what is food poisoning.
Oh, okay. Okay. All right. I hope you can hear me.
Loud and clear.
Okay. Yeah. So when we say food poisoning, it doesn't necessarily mean that some patients or Zoko has gone to put some poison in your food. Okay. So that's not what it means, as we see in the movies. It means that you are having signs and symptoms related to your food being contaminated. Okay, your food being contaminated. And the contamination may have occurred either during the preparation, during the storage, or during the time that you are consuming the food. So sometimes some of the microorganisms, they will produce what we call preformed toxin. This means that once the food is contaminated, they produce the toxin on the food itself. Then you eat and consume this toxin. Okay, so immediately you eat and consume this toxin, then it starts having its harmful effects right away. Some of them you have to eat, then the microorganism goes inside, now establishes an infection, and then release their toxins. Then those toxins will now give you symptoms. Symptoms such as abdominal pain, very bad abdominal pain. Some will have diarrhea, vomiting. It can be so bad that some patients will even go into acute renal failure. Okay, some patients will go into, some will develop electrolyte abnormalities because of the food poisoning. Some also just get septic. Okay, their system becomes overwhelmed with the infection to the extent that sometimes their organs start shutting down because they have eaten contaminated food. So that's it. That is basically food poisoning and how it occurs.
Doc, can food poisoning lead to somebody's death, and how?
Yes, food poisoning can lead to somebody's death. Number one of the commonest symptoms is diarrhea. So you can lose fluids from your body so much to the extent that it's not your blood volume reduces to the extent that the blood is not able to go and then perfuse or supply the vital organs in your body. So just by losing a lot of fluid, the person can die. Number two, you also lose electrolytes along with the fluid. And some of the electrolytes, like potassium, for instance, is very essential for the heart to function. So if you lose so much potassium, the heart may stop functioning. And then sometimes the infection itself, the bacteria, because of the toxin they have produced, that person gets what we call sepsis. And sepsis, as we have come to know, is a multi-systemic disease. It affects almost all the organs in your body. So the sepsis can cause your kidneys to shut down. It can cause your heart to malfunction. It can cause your lungs to malfunction. It can cause the brain to malfunction. And all these effects can definitely lead to somebody losing their life. Okay, it can cause somebody to lose their life. So, yes.
Thank you. Thank you very much. My next question, Doc. What is hernia, and who can have hernia?
Okay. So hernia, I try to explain in the abdomen. we have what we call fascia. Okay, fascia is a tough fibrous tissue that supports the abdomen. And it is the reason why we don't have our abdominal organs protruding or showing through our skin. Okay. Now, for one or two reasons, some people have a weak abdominal fascia, either because of a previous surgery they have done, or some are born with the defects already. Okay, so some are born with a defect already. So such people, sometimes if they do any activity that causes them to strain and increase the pressure in their abdomen, then the hernia forms or becomes evident. Some of them, they don't even have to strain. Okay, the weakness is so bad that even without straining, the hernia becomes evident. All right, and hernia can occur in males, can occur in females, can occur in adults, can occur in babies. Even newborn babies may have hernia. Okay, so everybody can get hernia. And when it happens like that, then it's better that a surgeon sees and then makes a plan to correct it. It can occur in your groin. It can occur in the umbilicus. Okay. You see a lot of children in some of our villages with very huge umbilicus. Okay. It's actually an umbilical hernia, all right, that they have. The opening at the umbilical area, it didn't close well. So they have a hernia through that. Some people too, after surgery, they may develop a hernia through the previous surgical sites. Okay.
Thank you
All
very
right.
much,
So,
Doc. Thank you very much. Thank you very much for the clarifications. Now, my last question before I open the floor for other people. So, if you have any questions, please drop them in the chat box in the comment section. Dr. John J.C. Benny will gladly answer all for us. He's an expert on just tapping more from him for everybody's benefit. Doc, I heard you do your presentation that for every woman in reproductive age group, when you come to the hospital with any condition, you are likely to be tested for pregnancy. How common is ectopic pregnancy and what is it?
okay. So, ectopic pregnancy is, I won't say is very, very common. Okay, but it's something that is serious and therefore we don't want to miss. We see it quite a bit in young women, all right, especially in patients who have had repeated pelvic infections that wasn't properly treated. Okay, so some people, they say, oh, menya white, then they go and buy some medication out there on the markets. All right, with the repeated pelvic infections, usually they may get scarring in the fallopian tubes. And if you get scarring with time, then the lumen becomes narrower and it's not straight. Therefore, you are prone to getting ectopic pregnancy. Okay. So it's not something that is very, very common, but all the same, it's one of the leading causes of maternal mortality in Ghana and worldwide as well. In Ghana, if you take the top 5 reasons why a pregnant woman will lose their life, ectopic pregnancy is one of them. So it's still a leading cause of maternal mortality that deserves our attention. Okay.
All right.
I've forgotten the other part of it.
I was just asking how it presents.
Okay. Yes. So typically the woman may have missed the menses, or sometimes in quotes, they will tell you, oh, my menses 2 weeks ago. Then they are now having their menses again. Their menses in quotes. And then they will be having lower abdominal pains. And some of them, they will have dizziness, palpitations. That's they become aware of their heart beating. And for some, they collapse. Okay. For some, the first presentation is a sudden collapse. The person was well, they woke up, going about their duty, then suddenly they collapse to the floor. Okay, so these are the commonest ways by which they present. But most of the time, is the lower abdominal pain that prompts them to actually come to us in the hospital. It's a lower abdominal pain. Otherwise, if it gets to the late stage where the ectopic pregnancy ruptures and they start bleeding into the abdomen, then they may have signs of anemia, which I was talking about: dizziness, palpitations. They get tired easily, even if they take a few steps. Okay, and generally they may also look pale. If you look at the person, you realize that they look pale. Okay. Yes. So these are some of the signs. These are some of the ways by which they present to us in the hospital.
Yeah, Doc, I heard you mention something very serious about some ladies who, in a bid to terminate an unwanted pregnancy, may go do other things without knowing where the pregnancy actually is. So it could be actually be an ectopic pregnancy, but they try to terminate it and they think they've succeeded.
Yes.
So they are the ones who present late.
Yes.
Okay.
Yes.
Thank you.
Yes.
Thank you very much. Now, a question in the chat box: what is alcohol abuse? Is it preventable?
Chief, this one lies within your domain.
Okay, let me try
Yes.
helping. So, Mr.
Yeah.
Questioner, alcohol abuse, per what we are working with now scientifically, is when you take alcohol in a week above certain units, okay, preferably above 14 units per week. But even now, the evidence suggests that we don't know how much will cause you damage. So we don't want to put a cut on it. So abuse is whatever is going to cause damage to your system. That's an abuse. And is it preventable? Yes, it is 100% preventable. It's a matter of behavioral change. All right. Mostly people start with experimentation, then social use, then habitual use, then addictive and dependent use. So you experiment and see how it tastes, how it feels like when you take it. Then socially, once in a while, when you go to programs, and then habitual. That means you take it almost every day before you eat, or you take it every day after work, or you take it every weekend. Then addictive, where independent use, where your body becomes used to it that you have to use it at all costs to feel okay. At that point, you need serious help. And we are able to help a lot of people. So if anybody like that, you need help, we are willing to do so. So that's the first question. But the second one, I'll still push it to you. Dr. John Jesse, I read alcohol
Yes.
health. The second question is this: I read alcohol helps fight certain abdominal issues. If it is true, for someone who's never tasted alcohol, am I at any risk? Doc.
Yes, I heard the question. Yes, I am yet to come across a scientific paper on the benefits of alcohol. Benefits of alcohol to the stomach. Okay. I know somewhere in the Bible, was it Paul advising Timothy to take some alcohol because of his stomach problems? I think maybe that may be the root of the basis for this question. But scientifically, I'm yet to come across the benefits of alcohol to the stomach or to the GI health. So I can't speak to this. And if you are not taking alcohol, you are not missing out on any health benefits, supposed health benefit from alcohol. Yes. Thank you.
So, Mr. Gakenke guy, keep it up. Don't taste alcohol. Just remain as you are. Okay, somebody is asking, how does UTI cause abdominal pain?
Okay, so urinary tract infection is infection along any part of the urinary tract, whether lower or upper tract. So all the way from the urethra to the bladder to the ureters. Okay. If you have what we call pyelonephritis. You know where the kidneys are located? They are located in your flanks. In your flanks. Any pain along the tract can be transmitted along these areas, and then you feel it as abdominal pain, but more in your flank area. So patients who develop pyelonephritis, for instance, pyelonephritis is when you have an infection that has spread to involve some parts of the kidneys. Okay. If you have that, the pain will mostly be felt in your flanks, and your flanks are part of your abdomen, if you remember the figure that I showed earlier on. So that may be felt as abdominal pain. Okay. So that's how come UTIs, can present as abdominal pain.
Right. Thank you very much. Thank you very much. Any more questions, please put it in the chat box in the comment section, and Doc will gladly answer for us. Thank you very much. Just like Doctor said, alcohol doesn't have any health benefits. Please, we don't know any. If for anything at all, we eat a lot of fermented stuff already, so we have some level of alcohol in most of our diet already. So whoever is not taking alcohol, you're not missing out on anything at all. Any questions, please put it in the chat box. We have some few more minutes so that doctor can help us. Any emergency condition at all you know of, please put it in the chat box, and Dr. John Jesse will help us gladly. You all understood why I call him consultant, because consultant is somebody you consult. So as far as I'm concerned, he's a consultant. Yes, that's what he is. Any questions, please put in the chat box. A few seconds more for us to go. Doc, can you make some statement on ulcer? These days, everybody's labeling themselves have ulcer. What would you say about that? Briefly again for us.
Yes, hello. Yes, so ulcer, like I was saying, simply when you have a break in the integrity of the mucosa that's lining the abdomen or lining the stomach or the duodenum, okay, in terms of peptic ulcer, and is related to a bacteria that we call Helicobacter pylori. So this bacteria, usually you have acid in your stomach. Okay, you have acid in your stomach. The acid is supposed to help us digest food. Okay, we know that acid is corrosive. The stomach is designed such that you have a very good or very strong mucosa. When I say mucosa, the lining of the stomach is very strong because of the acidic nature of the stomach. Now, if by the activity of this bacteria, you have a break in the mucosa, then the pain that you experience because you have this acid being exposed to an area in your stomach that is not protected by the mucosa. Okay. And this can occur in any part of the stomach. The stomach has parts. It has the antrum, it has the fundus, and then the antrum as well. Or you can have it extending into the duodenum as well. Okay. If you have ulcer, what we try to do is to, number one, relieve the symptoms. And then number two, eradicate the bacteria that is also leading to this particular problem. We don't just say you have ulcer because you have abdominal pain. No. As always, we need to assess you. And the assessment involves listening to your story and then now examining you, and later on letting you do an investigation that we call an endoscopy. Okay. So if we do the endoscopy is like a tube that has a probe at the end. The probe lets us see inside your stomach and your intestines in real time. So it's like watching a video of the esophagus through the stomach going into the intestine. So that endoscopy helps us to see all around your esophagus. It helps us to see all around your stomach, helps us to see all around your small intestine. Okay. Now, I forgot to mention another risk factor for this peptic ulcer. Patients who abuse pain medications that we call NSAIDs. I mentioned the examples of the NSAIDs earlier on. Now, your stomach lining, there is a chemical in the body called prostaglandin. That prostaglandin is what helps you to maintain the inner lining of the stomach and then, the stomach. If you take in these pain medication, these NSAIDs, when they are not indicated, then what you are going to do is you are going to block the action of the prostaglandin. And if you block the action of the prostaglandin, then that inner lining that protects the stomach is lost. Therefore, the patient now becomes prone to getting peptic ulcer. Okay. So, peptic ulcer, we diagnose mainly by doing the endoscopy that I described earlier. If you've not done endoscopy, we may suspect that you have peptic ulcer, but then we can't say for sure that it is peptic ulcer because it could be other things, as I explained in the presentation. Okay, so not every ulcer is ulcer. Some ulcer is cancer.
Yes.
Some ulcer is cancer. Some is pancreatitis. Some is because of hepatitis. Some is because of something else. And it's not really peptic ulcer,
Yes.
as we say.
Yes.
So I would say that we should be cautious with labeling ourselves as having ulcer,
yes,
without having gone through the necessary investigations to come to that conclusion. And if you have peptic ulcer, it is treatable. It is treatable. There are medications, a combination of medications that are given to you to, number one, reduce the acid production. Number two, to treat you of the bacterial infection or to eradicate the Helicobacter pylori infection. Okay. And then number three, there are other things we tell you not to do so that you don't block the production of prostaglandin, therefore make yourself prone to getting peptic ulcer.
Good.
Okay. So that would be my word on ulcer.
I like the deep explanation, the extensive explanation on ulcer. A lot of people are going to now. Just before we finish the ulcer issue, Doc, it's becoming fashionable these days for people to go and do H. pylori tests in a hospital. If it's positive, does it mean you have ulcer?
It doesn't mean that you have ulcer. But if you have H. pylori infection, you are prone to getting ulcer. Like I say, ulcer is basically diagnosed on endoscopy.
Yes.
So without having done the endoscopy, it's very difficult for anybody to say for sure that you have ulcer. I'm sure a lot of people have H. pylori infection and in their lifetime, they never develop peptic ulcer.
Yes. Thank you. Thank you. Now, another thing which is very common in most hospitals in Ghana these days, and a lot of people have been brainwashed, typhoid. Doc, a lot of people say they have typhoid, and almost every month they say their typhoid has come. Their typhoid has come. What is typhoid? How does it present?
They have personalized the typhoid.
Yes, it is not their property.
Okay. So typhoid is an infection that is mostly diagnosed clinically and then confirmed with what we call culture, either a blood, a urine, or a stool culture, depending on the time the patient is coming to see you. Okay. So typhoid, as I know it, a lot of the tests people are doing around, they are even doing the what do you call it? I've even forgotten the name. It's been a long time I saw that test.
Is it Widal?
Widal, thank you, Widal. So the Widal is not sensitive for the organism that causes enteric fever or typhoid fever, which is Salmonella typhi. There are a lot of other Salmonella species that cross-reacts with the Salmonella typhi. Therefore, if you have an infection with those other Salmonella species, most of them harmless, the test may come out as positive. Okay. But usually patients with typhoid, they will have fever, they may have chills, they may have headache, they may have abdominal pain. And then they will come to you. You examine them, you try to rule out all the other conditions, and then you sometimes request a culture or the antibodies as well. These are supposed to help you. They don't in themselves make a diagnosis of typhoid. They are supposed to help you put all the clinical information together, put the labs also together, and then make the diagnosis of typhoid and then treat it. And typhoid, as we know it, is treatable. It's treatable. Okay, it's treatable. Somebody may harbor the infection and then transmit it. They may be chronic carriers. But then for the one who has symptoms, okay, this is a treatable infection. There are antibiotics that can treat the typhoid infections. Okay. Otherwise, if it's untreated, it can lead to some other complications. Some of them neurological complications, some of them surgical complications, such as typhoid perforation. Okay. So it's a treatable infection. It's not something that anybody should be tagged with. That's typhoid. And some people I know, they go every month to collect typhoid medications. Please, exactly. It's not like that.
Exactly.
It is never like that. It is never like that. Yes.
These days, a lot of the labs in the hospitals are doing IgG and IgM tests. What are the implications of those labs when it comes out positive or negative? What does it mean?
Okay, so basically, if you have typhoid, usually the IgG, IgM, they indicate the state of infection. Okay, so if you have an acute infection, usually the IgM, immunoglobulin M, to the typhoid is the one that comes out as positive. And if it's a chronic infection, then it's the IgG that will usually be positive. Okay. So, but like I was saying, these all help us. They help us to make a decision, make a clinical decision. At the end of the day, you are not going to treat the lab. You are going to treat a patient. You are going to treat a person. Okay. So these help us to manage our patients.
Doc, you made two very profound statements. The first one is that the typhoid test that is run in the hospitals, it can come out positive as a result of other species of salmonella that's cross-reacting. So a positive test does not necessarily mean you have an acute infection. Is that what you meant?
Yes, that's what I said.
Exactly, good. So most people keep going and they test and it is positive and they go and take medication. 1 week, next month they go and take. So it becomes something chronic and they just label themselves with typhoid. That is why I needed you to give us this clarification. Thank you very much. Yes. Any more questions anyone has? Today I had a lot of questions myself so that it will help a lot of people. Thank you. A lot of people are just appreciating you for a good work done. I have a lot of comments from the YouTube. It's a very educative presentation. Thank you very much. Anybody else have any question? Any question to ask Dr. John as he leaves in the next 30 seconds? Anybody else have any questions? Any questions? Abdominal pain is quite broad. The causes are different. He took his time to take us through all the quadrants, all the regions of the abdomen. Somebody asked a question, but it is unrelated to the topic. So, Madam Bell, I will post the link to the YouTube channel of these presentations. We've handled that already on the channel, so you can go through the videos and you'll be glad you did. All the answers are provided in the video. We had gynecologists come on to share with us about irregular menstruation causes and all that. All right, so I'll post the link to the channel so that you can go watch the video on that channel as well. If anybody have any question, please post it now, and Dr. John J.C. Benning will help us to. Please, can you pronounce your full name for us again? I always have difficulty with it.
Hello?
Can you pronounce your full name for us again?
John Godswill Jesse Benin.
Today I got it right, Benny. I got it right. All right. Since school time, I've never been able to get it right. Oh, I'm doing well now. I think I'm doing well. All right, guys. So Dr. John Goswill Benin Jesse, thank you very much for spending quite a lot of time with us, taking us through all the things we need to know. I took note of all of them, and I just brought out the very salient ones that are very pertinent these days. We appreciate you, and of course, once in a while, we will call on you again. Once again, to the rest of you who join us online, and those of you who are going to be listening and watching this video, thank you very much. We appreciate you. Those who have not subscribed to the channel yet, please just subscribe, put the notification buttons on so that you can always benefit from those that have been recorded previously and the subsequent ones as you put the notifications button on. Once again, it has been a plum, pleasing pleasure serving you all. Until I see you again, this has been Albert.